Lovely good morning, my dear friends, and a warm welcome to the last session of oncosurgery. Herein, till now, what we have talked about, we talked about the various GI malignancies, we talked about various urinary malignancies. In GI malignancies, we talked about the oral cancer, esophagus, stomach, the colorectal cancer, the anal canal cancer, gallbladder cancer, pancreas cancer. In urinary malignancies, we talked about kidney, bladder cancers, prostate, penis, and testicular cancer. So we all understand the concepts nicely, that why the cancer occurs, how the patient presents, how this cancer spreads, and how we can investigate these patients and do a proper staging, and then depending on whether we are able to remove the cancer from the patient's body or not depends whether we are going to do a curative treatment or a palliative treatment. The only problem in different malignancies is they present to us late, and by the time patient comes to us, the cancer might have already spread, and then the curative treatment becomes almost impossible. But if the cancer presents to us at an early stage, we can make the early diagnosis and we can do the treatment adequately, and thereafter, if adequate treatment has been done, the patient will be leading a normal life after that. Right. So today, beta, we are going to discuss about the thyroid cancers and the breast cancers. In thyroid, if we just try to take a look, the thyroid malignancies, we know that in the thyroid gland there are follicular cells, there are parafollicular cells, majority are follicular cells. So majority of malignancies in the thyroid, they arise from the follicular cells. So ideally it should be a follicular cell carcinoma. But what we have observed, beta, that whenever a follicular malignancy is growing, majority of these follicular malignancies, we find a finger-like projection in them. And if you find a finger-like projection in them, these type of malignancies, they behave a little differently from those malignancies which do not have those finger-like elements inside. So malignancies arising from the follicles, they are classified as papillary cancers and follicular cancers. Papillary cancers are much more common. Papillary cancers have got a better prognosis. Papillary cancers, they spread commonly by lymphatics. Follicular cancers spread commonly by blood. These are differentiated thyroid cancers, papillary and follicular. Sometimes malignancy can arise in such a way that there is huge number of mitosis and pleomorphism, and then it becomes really difficult for us to differentiate the different type of cells. When we are not able to differentiate the cells nicely because of huge number of mitosis and pleomorphism, it is a fire type of cancer, then we call it as undifferentiated cancer, and that really has a poor prognosis. Sometimes cancers in the thyroid can arise from the parafollicular C cells, and then we call them as medullary thyroid cancer. Sometimes cancer in the thyroid can arise from the lymphoid tissue in the thyroid, and then malignancy from lymphoid tissue is called as lymphoma. Sometimes cancers from other areas can metastasize to thyroid. For example, kidney cancers can metastasize to thyroid gland. Breast cancers can metastasize to thyroid gland. So this is how we can find different types of malignancies in the thyroid. Let's take a look. In the thyroid cancers, most common are the differentiated thyroid cancers, most common being the papillary, second most common being the follicular. However, there can be undifferentiated thyroid cancers, which are called as anaplastic cancers, which have a poor prognosis. Sometimes malignancy arises from the parafollicular C cells, they are called as medullary thyroid cancers. Malignancy arising from the lymphoid tissue, that is the lymphoma, and metastasis to thyroid can come from other cancers like kidney cancer and breast cancer. Since most common malignancy is the differentiated thyroid cancer, papillary thyroid cancer, and the second most common being the follicular. Let us take a look at some small differences between these papillary and follicular. As we were discussing, that papillary are much more common as compared to follicular. Usually papillary cancers presents in less than 40 to 50 years of age people, while follicular cancers present after 50 years of age. The commonest reason for papillary thyroid cancer is irradiation to the neck. Radiation to the neck. Especially, just imagine a child who is receiving multiple x-rays of the neck or multiple CT scans of the neck. The radiation exposure to the thyroid is more, and there are high chances that this boy or girl will be developing thyroid malignancy later in life. Also, in pediatric surgery, we talked about a pathology, thyroglossal cyst, and the complication what can occur in thyroglossal cyst is a papillary thyroid cancer. So these can be the reasons for papillary thyroid cancer. Apart from this, there may be mutations in the red proto-oncogenes. In follicular thyroid cancer, the commonest reason is a long-standing endemic goiter. Long-standing endemic goiter. When we see them pathologically, then in papillary thyroid cancers, we find two characteristic features which are the favorite questions of your examiners: orphan aniide nuclei and psammoma bodies. If we take a look at the images, how they actually look like. Now here in this particular picture, beta, what you are seeing, these are the nuclei, and there is nothing what you are seeing inside. So these are empty nuclei. Orphan, anath, akele, orphan aniide nuclei. This is a characteristic feature what we see in papillary thyroid cancers, right? So this can be asked as an image-based question also. They might give you this image and they may ask you what, make the diagnosis. This is a case of orphan aniide nuclei which is seen in papillary thyroid cancer. Apart from this, in papillary thyroid cancer, we can see the psammoma bodies. Now this what you are seeing, this is a psammoma body, right? Seen on histological examination. These psammoma bodies can be seen in various other malignancies also. For example, serous cyst adenoma of ovary, papillary renal cell carcinoma, salivary adenoma, pituitary adenoma, meningiomas. We can find these psammoma bodies, right? So by these two things, orphan aniide nuclei and psammoma bodies, we can identify these papillary thyroid cancers. Follicular thyroid cancers are usually capsulated, and herein we find this structure what you are seeing, beta. This is the capsule, and here if you see, there is huge number of mitosis. There are huge number of cell proliferations what you are seeing here, and if this breaches the capsule, this is called as capsular invasion. As you can see, the story ideally should be confined within the capsule only, but here you can see the mitotic cells. They are actually breaching the capsule and they are going outside. This is called as capsular invasion. So if there are follicular cells where we find a huge number of mitosis, it can be either a controlled hyperplasia or uncontrolled hyperplasia. If it remains controlled, if it does not invade here and there, then we call it as follicular adenoma. But if it starts invading into the capsule or maybe into the nerves or vessels, we call it as follicular carcinoma. So whether it is a follicular adenoma or follicular carcinoma, the patient is going to present with a swelling in the neck. And when we do ultrasound and ultrasound guided fine needle aspiration cytology, we are actually putting the needle in cytology like this. So this needle is not going to tell us that whether